Dr. Bhattacharya, Dr. Sanjeev Banerjee, and Dr. Deepanjan Pal. Essentially, this entire instruction course is from Disha Eye Hospitals, and they are all cataract consultants from Disha, young Turks of Disha. So essentially, in this course, we'll try and attempt to give you the nuclear management part of phacoemulsification, because that is what is different between SiCS that we all do, and the transit is only phacoemulsification, is the nuclear management. Do not try to take notes at the end of the course. If you want a CD, there is a CD, you can collect it. So just pay attention to what is being talked and shown here. And this course is also available on YouTube, so you can go and download this. Just you need to type my name and the topic, and you can get it on the YouTube. Now, why do we really need to convert from SiCS to phaco? Because in majority of the cases, this is the wow factor that we get in phacoemulsification, a feeling that we have not been operated on the very first day. And of course, the astigmatism and other factors also come on. And so the happy SiCS has to go to a more happier phacoemulsification. Now, to begin, you need an access to a better microscope maybe, because what we cannot see, we cannot do. So you need to see things well to do phacoemulsification. You need to have a predictable phaco machine, maybe a Laureate or a Otley, or no financial interest, or a compact. Because, you know, in the learning stages, if we don't, there'll be hiccups. And you don't know whether it's a machine problem or whether it's actually your problem. So that's why we need a good predictable machine. And you must be doing regular OTs, because, you know, if you are doing once a week, then you actually forget the next week. So something that you had learned the first week, you forget it in the second week. So spread your surgeries in at least 2 to 3 days a week. This is lost by aspiration and also from some leakage from the side port. Now, aspiration, like in a Simcoe, we push it by a syringe. Here there is a pump, and by raising the aspiration, we are actually increasing the speed of the motor of the phaco machine. And just like we put more pressure on the thumb. And greater the aspiration, more will be the followability. Things will happen faster. But at the same time, it's risky because you can catch something, the iris, the capsule, something undesirable. So that's the downside of it. The upside of it is that everything flows to the tip. Now, but the vacuum is when something comes to the tip and occludes the tip, then we preset the vacuum and the motor still continues to move. So instead of, because the tip is occluded, it cannot take fluid from the eye, so it takes fluid from the machine. So when it takes fluid from the tubing starts collapsing. So this collapse is measured by a vacuum sensor, and we preset it to a particular level. And so the vacuum actually gives the holding power. The more the vacuum, greater is the holding power when we are chopping or when we are emulsifying. So for harder cataracts, for emulsification and also for chopping, we need higher parameters of vacuum. The downside of vacuum is that the moment the occlusion is broken by energy, after we have engaged something, we will give energy. The moment there is an occlusion block, if the vacuum is set very high, then suddenly, you know, the tubes have collapsed a lot and suddenly they swell. And this swelling also depends upon the aspiration time. The aspiration is higher, the vacuum will suddenly be released, and so there might be a surge. So higher parameters have these downsides, but they have the advantage of greater followability, greater holding. So about energy, I think we have three forms of energy. One is the continuous energy. One is a power saving energy, which is called micropulse. So, and the third one is a oscill, which is a torsional energy. Now in higher end machines, you will get only one machine is available with torsional. They have some kind of a patent. But micropulse is a very soft energy and very friendly to the cornea. And linear or continuous energy is, to be used while you are trenching or while you are impelling. When you're trying to hold something, you need good energy, because stronger energy. And softer energies like micropulse or torsional can be reserved for emulsification. So I have given the parameters. Generally, it's 30, 300, 40, 400. That's the relationship between aspiration flow and vacuum. And like in trenching, you don't need vacuum. So you have set the flow. Only what you have emulsified, the little that you have trenched, you need to take it off. So low flow, low vacuum. So this is all that things that we want to know about phaco-dynamics. There are too many other things which are probably unnecessary and clogs our mind. I don't think we need to go into those details. Now the first thing that I would very strongly recommend is we go for wet labs. And wet labs can very easily be done. This is just a thermocol block where there's a hole punched out. And you take the goat's eye, which are available in every meat shop, and you can have your own inventory, keep it in the fridge. And you have done SiSiS. So now we will tell you, because you need to practice that equipment, that machine, and you must do a lot of wet labs. And this is how we recommend it to be done. Once you've fixed it, now you do your SiSiS incision. And I tell you, in our hospital, we do phaco training, and we ask them to do at least, 100 of these wet labs. And when they are approved by our technicians in the wet lab, then only we allow them to go to the eye. Because you can make any amount of mistakes here, but, it shouldn't cost anyone in the learning process. So the wet labs are perfectly fine, because the goat's cornea is big, so you have to give the corneal incision for the phacoemulsification a little in front. See how nicely you can practice the rhexis. Even if you have some hiccups on the rhexis, this is the near closest thing for the rhexis. So practice the rhexis in the goat's eye. And we strongly recommend this stage, this step. Do as much as you should. See, it was like an onion peel stuff. Now the rhexis is made a little small for obvious reasons. Now take your machine. Now if you do it in any other form, because this is almost like the milieu. So, the phaco handpiece, the ultrasound handpiece doesn't damage. So you can use the original equipment and just keep on doing this. So when you are confident that yes, I'm done it there, so you can go ahead and do. So you have to sculpt a bowl. Get the feel of the machine. You have to come to foot position 3, where actually the power is activated. You trench, then you see, get that friendliness with the machine. And then, just like an SiSiS incision, sometimes, these pigments and the iris of the goat's eye is disturbing. Chop it off whenever you want to. Now you have done your SiSiS, maybe 4 cases in the morning. Take those nucleuses. You want to make the nucleuses hard, you can dip it in formalin and it becomes harder. Now do just the reverse that you have done in SiSiS. Instead of bringing the nucleus out of the bag, you put the nucleus in the bag. So this is the setting for the goat's eye wet lab. And now you can just go ahead with your phaco probe and try all that you read in books, see in videos, and that is how you groom yourself. Now you can just go in, do the trench as we will be telling you to do, crack the nucleus, chop the nucleus. You want to do a direct chop, you want to shift from trench to direct chop. So any change of practice that you would like to do, the goat's eye is a perfect model, perfect simulation Very easy, very economical, and do a lot of it. I still remember a guy who came from Germany. He was a young guy. He was in vitreoretina, not even in vitreoretina. He was in medical retina. He was just giving injections, very little exposure to microscopes. And he went through these wet labs, and he did 20 cases in our hospital as a part of that whole training process. And when I went to Stuttgart, he called me and he was practicing. He was practicing in Stuttgart next to the Mercedes-Benz factory. He was doing so well. So, I mean, this conversion can be made very much simple. Now, if you do it in the goat's eye, you definitely do it in the human eye. But in the course, I mean, as I said, collateral damage must be minimum. Now, let us take you through some of the steps. We will deal with this at greater length. Now, here you see the two side ports being made. In the initial stages, stain every capsule because you need to see the capsule during the entire phacoemulsification process. Whether the capsule is given away somewhere, you need to be careful. You should be, while trenching and all that, you shouldn't hit the rexes. So all this, you need to stain the capsule. So you need, for the incision, you just go up and then straight in. So that's a two-plane incision, and I'm showing this geometry because these are important. The left hand should be at 5 o'clock because that is where you get the leverage for chopping. And the right hand should be to the subincisional cortex, the direction of the blade, the direction of the blade. If we give it like this, we cannot go to the subincisional. The moment we try to go, it will be overlocking, and the cornea, they will be striated and the visibility will suffer. This is another very important point. Of course, the one written on the top on the black is you must be seated comfortably, slightly to the right hand side, because we are all right-handed surgeons. We have this carrying angle. So, you know, if you operate like this, if you are slightly to the right of everything, it's easier. And, you know, when we are doing something new, we are tense. So we crouch, we are stiff. So, you know, just relax and have that relaxed feeling when you're operating. And these are better done in wet labs and, you know, then practicing it when you are actually in the theater. And this main incision should be directed towards the 5 o'clock region, towards the 7 o'clock region. This is important for the right hand rule because our probe is going to go like this. Now, if you make the incision on this side, I'll come to that, but what it says that, you know, that these two incisions on the side port must be 2 clock hours away from the main incision because we need not get overlocked with our hands. And this one, you know, when you have given, your probe is always, because of our carrying angle, our probe will go like this for trenching. Now, if you made an incision here, then we are actually hitting the right side, the left side of the incision as shown in the red dot. And there you can have an wound burn. And at the same time, you know, the entire thing is not comfortable to the process. So these are important points which we need to keep in mind. I would not dwell much on the rexes because you all do good rexes. The essential thing is that the chamber must always be well formed. Whether you do it with the needle or with a forceps, and every time whenever the chamber is lost, replenish it with viscoelastics, and the rexes should have been folded upon itself when you are doing it with the needle. Now, another thing is, as in SiSiS, you know that when you press the posterior lip, the incision opens. When you lift the upper lip, the incision opens. It is true for all valvular incisions. So this is also a corneal valve incision, the phaco incisions. So here, when the surgeon is doing that rexis so smoothly, and he's doing it through the main port, by doing through the main port, what is important is you get a better leverage. You can take your needle anywhere you want to go. But the main port may leak. But it won't leak if you can put the timer off. But the main port won't leak if you are resting your needle or your forceps on the upper lip of the incision. Because then You are not pressing the posterior lip, so the chamber won't collapse. The same SiCS formulas. And also, we shouldn't press inadvertently out of the apprehension by some forceps or something. We are holding it, we are gripping it, we should grip it and pull it up, not down. In apprehension, you'll see all the rhexis escapes, they occur close to the main incision where we are trying to do the rhexis. Because that is where we are a little overlocked, and that is where we tend to press the posterior lip. So, do a bigger rhexis. I mean, do the SiCS rhexis, because in SiCS we do a bigger rhexis because it's an exocapsular technique. Need to take the nucleus out because that is safe. Your phaco probe is not going to disturb the rhexis. And then, of course, because the entire thing, the next step is hydrodissection. So you have to reduce the intraocular pressure for the fluid to go and dissect. So you have to burp out the viscoelastic from the eye. So, and then in hydrodissection, go lift the anterior capsule and then inject a small bolus. Here the surgeons did it in one go. You may not. Sometimes it happens that you actually inject in the cortex. So, you don't get, the moment you realize it, before you have injected more, go to another one and try to do the same thing, because it has to actually cleavage the cortex and not do a delamination within the cortex. And after every injection, do tap and get the excess fluid burped out. So that helps any posterior blowouts. Now, when you are happy that the nucleus has disengaged, do this. I mean, you do this in SiCS, but practice it more. And practice it more with, and do it obviously with equal forces, because this is a common technique in SiCS to bring the nucleus out. And you must do it multiple times to free the nucleus properly, and do it with your left hand, because this is one thing that we as SiCS surgeons don't use much. So, be as fluent with your left hand, because with this hand you have to chop. So, get these things in place. And this is what I was talking about, that, that's what the surgeon's trying to say, that if you go like this, you're going to, this is the way we will go. So, if you go like, if the incision is here, you are uncomfortable, and also there can be a wound burn. So, trenching and all will be dealt with at great length by our, because the basic thing about phacoemulsification, you have to divide the nucleus at least into two. Like these nucleuses, grade 2, just have to divide the nucleus into two. Even if you have not chopped, you can just catch one part, bring it a little out of the bag and emulsify. So, initially, the only thing that we need to know very well is trenching and cracking. So, you can deal most of the cataracts except the supra-hard ones. So, these will be explained to you in greater detail, and of course, the cracking procedures also will be explained. Now, when you are chopping, I mean, the key to chopping is, if you are using a 30-degree bevel tip, see the two nuclear halves are also aligned around 30 degrees, so that there is full occlusion. Otherwise, if it is like this, half occlusion will happen. So, this is one thing. Pick up, don't be shy to go to the middle of the nucleus. You have trenched, go to the middle. Don't be superficial. And then just go to foot position 3 and come back to 2. Out of apprehension, we come back to 1. If you come back to 1, you are only irrigating, there is no aspiration, so the vacuum hole doesn't stay. So, these are a few things which you need to keep in mind. And, gently we learn this technique. And once you've learned chopping and trenching, cracking and chopping, I think our job is done. We can go ahead and do so this is just to show you once again, see the parameters. The vacuum develops, the energy is there, the energy is gone. See the hold. It's not the chopper which chops, it is the hold which chops. You know, you can even do it with a Sinsky. It doesn't matter with soft cataracts. Very hard cataracts, you need to really get into the substance, so you need something sharper. And emulsification, the only rule to follow, be in the center of the eye. Don't move your probe here and there. Things will flow, it will come, or use the left hand instrument to get the flow. At any point, you know, you're not comfortable. This is deliberate. We gave some pilocarpine to constrict the pupil. I mean, we had to put in a PMMA lens, so we had to enlarge the incision. You have to enlarge the rhexis if you want to convert. At any point of time, you are not comfortable, just convert, because you are very good at it. So give multiple incisions. It can be given by a scissors, long-ended Vanus scissors, or a capsulotomy scissors, or it can be done by just a bent needle, cutting it at multiple parts, but don't release it in only one part, because otherwise that's going to extend. And then the trick to convert from SiCS to SiCS is that globe should be very firm. You know, you need to pack the eye with viscoelastics so that you have the right scleral tunnel, the right incision, and then carry it on to the corneal valve. And of course, the valve has to be, the valve has to be in, you cannot use the phaco valve, because that's one incision. You have to make a totally separate incision. So these are the preliminaries with which we start, and now I request Dr. Sanjeev Banerjee to come and tell us about the choosing the case, the trenching, and the cracking.
Good morning, and thank you, Dr. Debasish Bhattacharya, for including me in this course. Case selection is very important for the beginners to start with. Right eye is preferred to avoid nose barrier. Grade 3 nuclear sclerosis is ideal. The pupil should be well dilated, and patient taking tamsulation should be avoided in initial cases. Cornea should be clear, and deep-seated eyes should be avoided. An adequate lid exposure is very essential. Anterior chamber depth should be of 2.5 to 3 millimeter, and shallow AC and hypermetropic eyes are difficult to work with, as very little space between endothelium and capsule. Deep chambers and myopic eyes is also difficult to work with, because of chamber fluctuations occur in myopic eyes. Red glow must be good, and second eye is preferred. Now coming to trenching and cracking. Because of angulation, 45-degree tips does more sculpting than occlusion less, and 15-degree tips gives more occlusion than trenching, and 0-degree tip gives occlusion only, and 30-degree tip is the ideal for trenching. Mild to moderate aspiration flow rate is required during trenching, as there is no followability or occlusion is required during trenching. And minimum vacuum is required during trenching, as only the fine trench material needs to be removed while trenching. And powered setting depends on the hardness of the nucleus. The harder the nucleus, more preset energy to be used. In softer cataract, soft energy like micropulses or torsional can be used. 1 to 1.5 millimeter of tip should be exposed from the sleeve. Trenching should start from 12 o'clock, the upper part of the rhexis margin, and it stops just in short of the rhexis margin at 6 o'clock position, and the trench should not cross the rhexis. If the cataract is hard, trench should be wide and long, and in harder cataract, more energy to be used. In softer cataract, the trench should be short and narrow, and less energy should be used. The angle of attack, which is the angle between the phaco needle and anterior surface of the capsule, and it should be 45 degree. If the angle of attack is less, we may superficially chip the nucleus and injure the rhexis. 1/3 of the tip should be buried during trenching to get it perfectly done. The energy means the resistance of the nucleus. The harder the nucleus, more preset energy to be used, and in the softer nucleus, less energy to be used. And if we want to emulsify more nucleus at a time, more energy to be used. If we bury the tip too much in the nucleus, the tip does not trench, but it pushes the nucleus. And same thing happens when you use less energy or be shy on the paddle. The nucleus is thicker in the center, so more tissue should be trenched in the center, and no energy should be wasted while coming back. The more energy should be used to trench in the center. Refocus the microscope every time to see it clearly, and small chips carefully removed during trenching, or otherwise we may blow a hole in the periphery. While rotating a nucleus, if we want to rotate it from the center of the nucleus, center of the trench, we get a very small lever of arm, so it will be difficult to rotate. But if we rotate it from the periphery of the tunnel, we get bigger lever of arm, and it will be easier for rotation. So while trenching, when trenching is completed, then the one end, rotate the nucleus 180 degree, and then the same thing is repeated in that area. And you can do a counterbalance for forceful trenching by fixing the nucleus with the Sinskey hook. While cracking, place two instruments at the deeper part of the tunnel and apply equal amount of force on either side. If we use more force with one instrument, we may create a traction in the opposite zonule. And if we place the instrument in the superficial part of the trench, it will be very difficult to get it cracked. While cracking should be initiated from the periphery to the center. If the crack is incomplete, rotate the nucleus 180 degree, and cracking can be completed from the other periphery. The center is hardest, so it is difficult to crack in the center. Moreover, we do not get a very good fulcrum. This video demonstrates how to do a very right trenching and cracking. The trenching initiated from the one side of the rhexis margin and fall short and just the opposite rhexis margin. The angle of attack should be 45 degree, and every time the 1/3 of the phaco bar tip should be engaged. When one side of the trenching is completed, rotate the nucleus 180 degree, and the similar steps are done at the other side. The tunnel width should be 1.5 times of the tunnel with the width of the phaco slabs to get it done very easily. These steps may be repeated if we want a very good depth of the trenching. And while doing deeper trenching, we need to focus microscope every time. We place two instruments at the deeper part and apply equal amount of force. Rotate the nucleus 180 degree to get the cracking done completely. Thank you. The next speaker is Dr. Mrinmoy Das. He will speak on incision.
Good morning, everyone. Yeah, Mrinmoy, just a moment. Before Mrinmoy starts, we'll go and we'll explain you the incision, the 4-quadrant, the stop and chop, and some chopping techniques. And I'm sure we will have at least 15 to 20 minutes for question answer sessions. So please keep your questions ready, whatever you want to ask. And so this is how we will go ahead with the course. Right, Mrinmoy, please.
Good morning, everyone. I at first want to thank Dr. Debasish Bhattacharya for including me in this fantastic course. So my topic will be incisions and 4-quadrant techniques. So incision is the first step towards the successful phacoemulsification. It can be superior or it can be temporal. For the beginners, it is better to go through superior incision because whatever surgery he has done previously, like SiSiS, ECC, pterygium excision, maybe trabeculectomy, all have done, he has done through the superior incision. So it is a very familiar position for him to do the surgery through superior incision. And the incision should be, it's always the incision should be clear corneal incision. Now the shape of the incision should be a square geometry because the square incision always withstands greater external pressure. It improves wound integrity, resists leaking, and avoids endophthalmitis. So there are 3 types of incisions we can use. The first is a single plane incision. In this case, you just directly enter into AC with a keratome. It may be 2.8 or 2.2 millimeter incision. And these are 2-plane incision where you first make a groove at the limbus with a 15 millimeter Bhattacharya blade, and then you advance your keratome and direct entry into the anterior chamber. So this is a 2-planar incision. And now coming to 3-planar incision, first make a groove with a 15 mm Bhattacharya blade, then lamellar dissection with the crescent knife, and then you can enter into the AC with the keratome. Now coming to side port incision, during side port incision you have to make sure that the dull edge of the side port should be towards the 6 o'clock because if in topical cases, if there is sudden bails, then the incision may become uncontrolled. And the tip of the blade, side port blade should be towards the 6 o'clock of the opposite angle. Towards the opposite angle. It should be towards the opposite angle. The side port incision, it should be a funnel configuration because funnel shaped incisions are there to increase the maneuverability. It minimizes the leak and it helps to minimize the stria. And the left hand side side port through which we use the chopper, it should be around 2 clock hours away from the main incision. Because if it is more than 2 clock hours, then chopper motion becomes more of a sweep. And if it is less than 2 clock hours, then the hands become crowded. After phacoemulsification, when you are closing the incisions, stromal hydration should be done, and it should be done very carefully to avoid detaching the Descemet's membrane, and always assess firmness and wound tightness at the end. A snugly fit phaco probe and incision gives a stable anterior chamber. But if the incision is tight, then the tight incision pinches the sleeve and reduces the flow, resulting in shallow and unstable anterior chamber. In case of tight incision, the ultrasound tip is very near to the main incision, so it touches the incisions and the heat is directly transferred to the incision, resulting in wound burn. Now you carefully see the tightness of this incision in these cases, and as the ultrasound energies we are using more and more, the whiteness of the upper part of the incision is increasing because it's too tight, so that the tip of the phaco probe it's very near to the incision and the heat is directly transferring to those areas. And you could see the CD ratio, it's already more than 40 only for the trenching, only for the 4-quadrant technique. And now you could see the fish mouthing of the wound and the chalky white appearance of the wound. So this is a wound burn. So the commonest cause of wound burn is tight wound. Always ensure fluid flow around the tip before applying the energy. and the maximum amount occurs mainly during the tip occlusion and the fragment removal stage. So put a suture in these cases to minimize the wound margin, or you create a separate entry to complete the procedure. Now coming to 4-quadrant technique, this is a safe, simple and classical technique. Every beginner surgeon should learn this and should try to make master of this this procedure, because here we are using energy away from the cornea, it's in the bag. So more energy also is not that much of you injuring the endothelium. So here first the incision is making, it's a biplanar incision. And now filling the entry chamber with the viscoelastics, and then the side port incisions are made. Now capsular exit started, and for the beginner a larger capsular exit is better. It should be around 5.5 to 6 millimeter of the diameter should be 5.5 to 6 millimeter. And after completing the rexis, the hydrodissection should be done. And during hydrodissection, after injecting fluid, always tap the center part of the nucleus so that the trapped fluid behind the nucleus should come out before you proceed. Then a good rotation of the nucleus is a prerequisite before the phacoemulsification. And then we start the trenching from center to the periphery, and then rotate the nucleus 180 degree, and we are trying to complete the trench. Then the trench should be deeper and wider so that during cracking it will be easier. Now rotate the nucleus in 90 degree, and then make another small trench, and then rotate it 180 degree to make another trench so that a plus sign is appeared. And now putting the blunt instrument inside, deep inside the trench, you just divide the nucleus from one side and then rotate it 180 degree. And the divide should be in such a way that there should not be any attachment at the posterior pole. So the posterior plate should be separated totally, and the nucleus is divided into the 3 parts. And always check that there should not be any attachment with the other parts also. And now it's divided into 4 parts. And now you just hold the one part of the fragment and take it out from the bag, because there is hardly any space in the bag at present. And you should emulsify the nucleus at the pupillary plane. Always use your left hand and try to feed the nucleus, and sometimes you need try to feed the nucleus into your phacoprobe. And always try to avoid chattering much more, because the chattered nuclear fragments can damage the endothelium at this stage. And for a vegan, it should be very your hand should be very stable, and if your parameters are good, then the nuclear fragment should come into your probe. And always you can take help from your left hand with the chopper. And the other parts also you are taking, you just take the nucleus from the bag and emulsify it at the pupillary plane, so that there should not be the phacoemulsification should not be done near the cornea. It should away the cornea, but it also should away from the posterior capsule, so that there should not be any posterior capsular rent during the phacoemulsification. Now coming the third pieces, third nuclear fragment is also we are emulsifying with the phacoprobe. And you could see that your right hand should not be in a very much greater movement. It should be very stable. And during the last part, you have to be very careful that you can take this nucleus out, and it should be away from the posterior capsule, because there is no support of the posterior capsule at that point, and it can come into a probe if the AC gets shallower. And in case of hard cataract also, the part of the nucleus which is shattered from the phaco tip, that can also damage the posterior capsule also. So your nucleotomy is almost complete, and then we will take the epinucleus out, and then cortical matter wash, and then putting the IOL. So thank you, and my next speaker will be Dr. Dipanjan Pal.
Good morning, everybody. At the outset, I must thank Dr. Debasish Bhattacharya to give me opportunity to speak in this wonderful basic instruction course. My take is on stop and chop. This was developed by Dr. Paul Koch, and it is basically a combination of Gimbel's nuclear separation and Nagara's in situ chop. This is a way just to reduce the energy consumed partly, until unless further we are moving into a chopping method. So the step 1 is creation of a space within the cataract by doing a trenching. That is already been described beautifully by our former speakers. Step 2 is cracking, also described, and the step 3 is chopping. Coming to the parameters for trenching, the power has to be according to the hardness of the nuclei, with a low vacuum and low flow, just to take away the emulsate. For cracking instruments, we can use phaco probe and the chopper, what we are already using during the phaco, or 2 Sensky hooks, as already been described by Mrinmoy beautifully. If fails, further deepen the trench and then retry. For chopping, parameter, the power is to be linear ultrasound or burst with a higher vacuum. That is very important, because if we do not hold or occlude the tip properly, we cannot chop with a high flow. And for fragment removal, power is micropulse, or recently with the higher end machines torsional, high vacuum and high flow. Now this is the most important part. While impaling, the nucleus must be correctly aligned to the bent tip of the phaco for total occlusion. Just we see this portion of the phaco tip is not properly occluded. And now, the moment we rotate the cracked fragment and it's aligned along with the edge of the tip, now the hold is good and chop will be easily achieved. Another important part is, if the probe is superficial, the hold is always weak, and also it can slip and injure the rhexis margin. So, simply, superficial hold doesn't chop. For proper chopping, we have to hold tightly on collar and give a tight blow on somebody's face. So coming to a video, remember the parameters for trenching, the power according to hardness, low flow, and we get a crack. Here we are using phaco probe and the chopper, and then align the probe properly, deeper in the center part of the nuclei, get the first chop, and then according to wish or the hardness of the nuclei, you can make 4, 6 to 8 fragments if required, and then take 1 fragment at a time slowly. Now this stop and chop technique is universal almost for all kinds of nuclear hardness. It is easy to learn, and from step by step, when we learn 4-quadrant technique, and this is the next part. Now I will request Dr. Bhattacharya to take us to the phaco chop technique.
Good morning, delegates. And again, I want to thank Dr. Debasish Bhattacharya for giving me a chance to speak in his IC. Now, my previous speakers have already give some information about the setting parameters, power, irrigation and all the things. Now, let us see how it works. Now, chopping procedure is the practically dividing the lens nucleus into multiple fragments by taking the advantage of natural cleavage plane of the lens nucleus. Now, what is the advantages of chopping? Here, we can reduce the phaco power and time, saving the ultrasound energy. We can reduce the stress on zonules and less reliance on red reflex. The most disadvantage of chopping is it requires a slightly longer learning curve. Basically, chopping are of two types, vertical and horizontal. Now, what are the indications of vertical chop? For the beginners, it should start in those cases where difficulty visualizing the capsular axis margin, like anterior cortical spokes in brunescent nuclei and very little or no epinucleus. What are the indications of horizontal chop? It is indicated mainly in soft and smaller nuclei, extremely deep anterior chambers like high myopia, post-vitrectomized eyes, and in case of very small pupil. For recapitulation, let us see the chopping parameters. Power, as we all know, that it may be continuous ultrasound or in burst mode. Vacuum, it should be high for proper holding, and flow rate should be high to clear the fragments from anterior chamber. And power can be of pulse type, burst type or continuous mode. And recently in some modern machines we can use the torsional, but it is not present in basic machines. Now, vacuum depends on nucleus grading. It should be proportionate with the force of chopping. We should set the vacuum in softer cataract. If we set it more, then it leads to failed occlusion. And in case of harder cataract, if we set the preset vacuum less, it will ultimately leads to loose occlusion. So basically, if we diagrammatically represent the stages of chopping, first is the engagement, then hold it properly with the proper preset vacuum, leads to occlusion, and chopping with partial occlusion is possible mainly in softer cataracts only. Now, holding, the first to hold the fragment, we should set the foot pedal in foot position 3, by which we can deliver the energy and let the tip enter into the core of the nucleus. Then come back to foot position 2, leads to partial occlusion. Gradually the vacuum increases. Let us reach the preset level and then the full occlusion will achieve. And then we should go to chopping procedure. What are the instruments used for chopping? Chopper, there are mainly two types, sharp and blunt. But recently, different companies have developed some various modifications of these two types of chopper as per surgeon's requirements. But a beginner should start basically with these two standard instruments, sharp chopper and blunt chopper. The sharp chopper, as the name indicates, has a sharp tip, 0.5 to 1.5 millimeter in length, and angulation is 90 to 100 degree. Blunt chopper, it has got blunt tip, 0.75 to 1.5 millimeter in length, and the cutting edge is inside of the tip. Now, chopping procedure is a bimanual procedure. So we have to introduce the left hand instrument in the anterior chamber through the side port incision. Now let us see a small video clipping how we should place the side port incision. If the side port incision is placed too close to the main incision, it will lead to crowding of the two hands, which will ultimately lead to the mechanical disadvantage and improper chopping. So here you can see the left hand incision is placed within 1 o'clock diameter from the main wound. So the surgeon is unable to crack the nucleus properly because he cannot apply the force properly. Now he took out the incision and place it a little away from the main wound. Ideally it should be placed from 2 o'clock away from the main wound, and you can see here that through this wound, if we place this chopper properly, you can crack the nucleus very nicely. Now vertical chop, how it works? Basically it cracks the nucleus and separates the fragment. So for proper cracking and breaking, we need to hold properly, and then you can chop it clearly. How it works? Let us see. Now create a space within the core of the nucleus because it is the hardest portion. Now place the instrument, the chopper, through the left hand side port. Now after impaling the phaco probe within the deep nuclear fragment, hold it, let the vacuum increase up to the preset value. Now bury the chopper and bring it close to the phaco tip. Rotate the nucleus. If the first chopping is incomplete, rotate the nucleus and do the same procedure. Then chop is completed. Before chopping, particularly in case of harder cataracts, debulking or central crater formation is advised to reduce the thickness, to reduce the hardness, and to create the space for chopping. Now let us see some video clips. Here the nucleus density is around, nucleus sclerosis grade 3. Now you can see the preset vacuum is 300, aspiration rate is 30, preset level, and the surgeon here holding the nucleus and chopping with the left hand. Now chop in situ with lateral separation. Here also the central core formation or debulking is done in the first stage. Now hold it properly, bury the chopper deep into the nucleus and separate it clearly. And what is the ultimate last moment up to which you can do the separation? The indirectly, when you can see the red reflex clearly through the crack, that means you have separated the posterior plate. Now multi-level chopping, particularly it is used in case of harder cataract, but definitely as Dr. Mrinmoy Das has told that a beginner shouldn't choose a case with such hardness of the nucleus. In this case the nucleus is much harder. Here if the surgeon fails to crack the nuclear fragment in the first setting, then release the power, release the vacuum. You should go much deeper, again impale the phaco probe in the nuclear fragment, and then again put the chopper. If you feel comfortable, then you can put the sharp chopper, or you can do this procedure with blunt chopper also and complete the crack. Now chopping in softer cataract, it is better to do horizontal chopping with blunt chopper, particularly in case of nucleus sclerosis 1 to 2, maximum up to 3. And here for a beginner, you should start with a little larger rhexis in a well dilated pupil, because you have to put the blunt chopper in between the margin of the anterior capsule, the rhexis margin, and you should slightly pull the nucleus so that you can see the periphery of the nuclear margin. Otherwise, inadvertently, you may put the blunt chopper in the beyond the rhexis and injure the zonular integrity. So vertical chopping basically indicated in harder cataract like grade 3, 4, 5 or 6, and horizontal chopping is indicated in softer like nucleus 1 to 3. So there are some common pitfalls in the learning phaco chop. As I have mentioned earlier, that not hooking the nucleus equator with the chopper, elevating the chopper tip as the chop is performed, chopper shaft presses down on limbus during chop motion, so more fluid goes out and the anterior chamber becomes shallow, and chopper placed outside in the zonular space, and phaco tip too superficial. So if we summarize the whole chopping procedure, impale, then hold it, chop it, and then emulsify. So happy chopping. Thank you very much.
Thank you, Bhaskar. And so this brings us to the all that we really wanted to tell you. Now we are ready for questions. Can we have the mics in places? And we understand and we fully appreciate that you are in various stages of the learning, so you can ask any questions that you want to. You want something in the advanced areas of phacoemulsification. You can collect a DVD if you want. Anirban is there? While you leave.
Excuse me, sir.
Yes,
I'd like
yeah.
one question.
Yeah.
Sir, I've seen at times while doing the trenching, a lot of air bubbles enter the anterior chamber. I'm not sure why. Sometimes they appear, sometimes they do not appear, these air bubbles. So what could be the reason?
Actually, you haven't primed the machine at the first place. And, though we go into the, in the eye, into the anterior chamber in foot position 0, I would say that you be in foot position 1 outside the eye so that you irrigate the surface of the eye, then go to foot position 0 and then enter the eye. So if there are air bubbles initially, that will come out. So it doesn't occlude you at the very beginning. And if it is repeatedly happening or happening in between steps, like when you are emulsifying, air bubbles are coming, that means your connector in the system is loose from where it is inviting air. So you need to tighten it up and reprime the machine.
Thank you, sir.
Yes, Shamalda?
As you were this session for the mainly the learning persons, so what is you are advocating for the soft cataract, whether they will go for the for 4 quadrants or the soft?
I get your point, Shamalda. Yeah, I mean, this is a very important question. You know, generally we would choose softer cataracts, and sometimes some of the cataracts may be very, very soft. Now, by saying very, very soft, those are also difficult cataracts for phacoemulsification, and because you don't have that formed nucleus. So, I think very careful trenching, divide the nucleus into 2, and don't have to chop these nucleuses, you can just emulsify them. Even, just trying to hold those epinucleus or that half or soft nucleus is difficult, and in that I think if you are failing, I think that is where a bigger rhexis comes into play, that those soft cataracts you can actually bring it out of the bag and just emulsify the nucleus, because there will be hardly any energy required to emulsify. So even if you are doing the whole thing slightly closer to the endothelium, we need not get bothered about.
Thank you.
Another thing, sir, to all of us, whenever you are feeling a little clumsy, like in some process, at least with the phaco probe, just bring out your phaco probe, irrigate with your Simcoe, you see what has happened, and you can see, and then you can compose yourself and then get in. At times, we have the pre-conviction that because we have to do the emulsification in one go, so we have gone in with the probe and we should not come out. So it is not that whenever we are uncomfortable, we should take out the probe. It makes visibility so much better. Yes, sir.
So Dr. Sharma here.
Hi.
Good morning.
Yeah, good morning, Dr. Sharma.
So you didn't touch about epinucleus. Sometimes I end up with a large epinucleus. How to remove it?
Absolutely. This is something which, as I said, delamination is probably not required, and absolutely, for beginning is not advisable also. But in case we have done, we could not achieve a good hydrodissection, you will be left with an epinucleus which you need to take out. Now, honestly, what would be the cortical cleaning instrument? We didn't even touch cortical cleaning, Dr. Sharma. Initially, there could be two outlooks to it. One, you have acquired the machine, now you want to go into phacoemulsification. So in your SiCS cases, do the bimanual. Do the bimanual automated IA. So, you can manage, because the incision is big. If there is a rent, you can do a vitrectomy and put the PMMA lens. So all this you can try. So one is you can, we would recommend to use your IA in your SiCS cases and get used to the machine before you get into cortical cleaning. The second approach could be that you are comfortable with Simcoe, so go ahead and use the Simcoe. Now, what Dr. Sharma asked, which is a very pertinent question, is sometimes we get bogged up with the epinucleus in the back. The pupil also probably has come a little down. And now how to get that epinucleus out? I think you have to again do a little bit of hydrodissection. You have to take the probe out, because, even the bimanual, probably if you can't actually catch it, it won't happen. So you have to go and again hydrodissect and get the epinucleus out of the bag. So the epinucleus has to be, and when there is this tamponade of the fluid, the irrigation, usually it is difficult to get things out of the bag where only, the posterior capsule and the epinucleus is there. So we need to do a hydrodissection again, or by viscoelastic. If you have found some cleavage somewhere, inject viscoelastic in that cleavage, the epinucleus is going to come out, and that's how probably you can do. So is there anything else that the panel would like to add? Mrinmoy?
In this time, in the left hand, we should use the blunt chopper. So sometimes, if you are not putting hydroelastics and you are taking out, you want to take out those epinucleus with your phaco probe, you just change your chopper from sharp to blunt, and then you can rotate
chopper
the
also,
nucleus.
what Mrinmoy says, with the blunt chopper also, you can try and hook up the epinucleus. Yes, please.
Good morning, sir. I am Dr. Bhattacharya from Moradabad. Sir,
welcome.
I want to know in soft cataract what must be the parameter while we are doing nucleotomy in soft cataract, sir.
Why you are doing your trenching?
No, sir. Nucleotomy.
Nucleotomy. Actually, first thing is, in very soft cataracts, yes, you must bring down the power, do it in micropulse, or because that is what we will have in your machine, and keep it around 40, 50, not more than that. But what is important is, first try to hold the nucleus, if it is very soft, only with vacuum. Keep the vacuum high, vacuum 400. Don't give energy. Be in foot position 2, the mere aspiration can also hold it. But if you see that it's not holding, then that has to be very smart and planned. Just go to 3, and come back to 2. One little force. We give more, you'll actually go deep in, and then that's epinucleus which will never hold. So that's the trick actually for chopping in soft cataracts. And of course, as Dr. Bhattacharya said, that you can try this in goat's eye. I would not recommend first hand, horizontal chopping, because you need to take the chopper, the blunt chopper, under the capsule, and from the rexis, under the capsule, down to the equator, and then turn it around and hook the equator of the nucleus, and that is how it chops. So that has to be, as we get more accustomed, I think horizontal chopping can be tried. So that's another thing. Yes. Any questions? We'll be happy to answer.
Yeah, sir, one question. Sometimes in phaco or even SiCS, we are doing hydro procedure. Suddenly the wound gets tight and the iris starts coming out, eyeball becomes tight. So, sir, these kind of scenarios are how to avoid it, and if it happens, what to do? And there is no space, suddenly.
Absolutely, it can happen even when you are at the end stage of cortical cleaning also. Why this happens is fluid misdirection. We have not given that hydrodissection between the capsule and the cortex. We have given it just above the capsule, so it has gone behind the zonules, and it has it is in the antihyaloid, and it has pushed the nucleus in front. So it's a situation where you have to go back, give mannitol, do a fundus examination, because it could be an impending expulsive also. And if you are committed to the same day surgery, if mannitol also doesn't soften the eye, then you can do pars plana vitrectomy. That will bring down the pressure immediately, if there is no expulsive hemorrhage on indirect ophthalmoscopy. Or else, I think you can just postpone it for the day, and it will be over. After 1 or 2 days, you can just do a smooth surgery. Nothing wrong.
Thank you,
sir. I just wanted to another thing to it. Hello? I just wanted to another thing to it. This is one thing, definitely it could be fluid misdirection, but it could also happen from us when you were trying to take out the nucleus or maneuver it through a very small rexis. The fluid can be trapped behind the nucleus in front of that we call capsular block syndrome.
Okay,
so if you suddenly happen to have a capsular block, then you have to be very careful, because this is just an impending nucleus drop. So the moment you go in with a phaco probe, there could be sudden giving away of the posterior capsule, the nucleus might fall. So in this situation, either you can very slowly you can increase the rexis if possible. Probably it won't be possible. You can tap the nucleus a bit for
release
a
the pent-up fluid.
little egress of the fluid from the rexis margin. So chamber becomes little easy to handle at that point of time.
Yeah, this could be another possibility, but if it is a very tight eye where you cannot do anything, usually it's a fluid misdirection.
What I did was just put mannitol and then give relaxing incisions and convert it. This is what had happened. So I thought maybe there is something more to it. Thank you, sir.
No, pars plana vitrectomy is something which is more to it. The surgery becomes very, very easy. No, I mean, I'm not talking about pars plana vitrectomy here, because we need to advance our frontiers. You need to have a lot of equipment for that.
Good morning, sir.
Yeah.
Any modification about choosing patient for toric IOLs?
Toric IOLs, they're wonderful things, yes. What do you want to know about toric IOLs?
Any modification in incision and anything like that?
Incision, of course. I mean, you can modify incisions to regulate your the pre-existing astigmatism. But per se, for toric IOLs, otherwise you can go by the incision that you want and give the chosen power. Toric IOLs are beautiful, because if you are operating in 6'9", 6'6" eyes, so you have to give patients something more. So you have to give them freedom from spectacles. So toric IOLs are perfect. There's nothing much to be practiced except the usual. You have a lot of lectures on toric IOLs nowadays.
Thank you, sir.
Any basic things or any machine questions, ask anything, anything that you wish to. But, you know, I would always emphasize, you know, please phase out your training process. In case you are in your training process, please phase out your training process properly, because the wet lab, I would regularly emphasize, wherever you may be in a NGO hospital, try to develop it. It's such a small thing. You can request your senior and just get his permission to have some microscope, tuta-futa, and some old machine also, because if you can manage to do with that old, you know, some very not so well functioning machine, you can do it with a better machine in the human eye. So if you are very comfortable doing with the bad machine, I mean, you can always work with a better machine. So wet labs are very important, and whenever we are in problems, you know, we suddenly feel very tensed and, you know, everything is getting cramped up. So just relax, take the probe out. First thing, take the probe out. And then just with the Simco or with the IA, just irrigate. So everything is clean. And now try to see what is the next step that we need to take. And that, I think, plans. Like when you initially don't try to chop with the probe and the chopper, because the probe is 8 millimeters, so that's occupying so much of space. You can't see properly where you are going, how much depth are you going. So take the probe out, use 2 Sinskis or Copelands, and then go in, start from the periphery and start giving equal forces, divide. Like these kind of things help a lot. So there is nothing great about phacoemulsification. It's just that Simco aspiration that we all use, and it has got an energy module in it. It has got an ultrasound energy module to it. Like in SiCS, you have so many techniques. Some even do a envelope technique and then complete the capsulotomy with a Simco cannula by just holding it and proving it. That's a Lahan technique. So we do so many things with and it's just a phaco probe is that big machine is not so big actually. It's just that it has got irrigation, it has got aspiration, and it's got a power which will emulsify things. And whenever there is occlusion, we need to emulsify. So it's as simple as that. So I think,
we have 5 to 10 minutes. I am Dr. Pankaj Sharma. I am in Jaipur. I am teaching in the hospital, working as a professor. I just wanted to make one point. How important are the sounds which come out of the machine? We have to train our ears to those specific peculiar sounds which come, like the aspiration or the vacuum or the phaco sounds. That has to be trained. I think we should stress on that.
Absolutely,
also.
Yeah. Like the ting, 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 which that's the vacuum sound, right? Rather the emulsification, the will happen. And when you are in the flow state, is so these are the 3 sounds you need to get used to. The aspiration flow is and occlusion is ting, 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 ting. So you are occluded, you are holding. And emulsifying is, if you have used pulse energy, you'll get that. So, yeah.
Sorry, sir.
Hi.
The last question, I think. One of the speakers mentioned about tamsulosin to avoid floppy iris syndrome. Now, what is the time, I mean, the best time before surgery when the patient should stop tamsulosin taking?
Patient should not stop tamsulosin. Doesn't help. Even if you have taken 3 years back, if the iris is floppy, it will be floppy.
It should be continued.
It doesn't help, so there is no point. We will be giving atropine or homatropine or some drops, and the patient might end up with a retention urine. So, I mean, there is no point because it doesn't help. I think David is a very good friend of mine, Dr. David Chang, and it's very clearly, who's identified the floppy iris syndrome, and so there's no indication of stopping. Now, how do you actually handle floppy iris syndromes? First thing, even atropine doesn't help preoperatively. nothing really helps. The only thing is, if you go in and you see that wobble in the iris, well, I would say use iris hooks. You know, don't mess, because once somewhere you have shaft the iris, then it becomes so messy, because once the pupil comes down, now there are pupil expanders. The Malaguin, Boris again is a very good friend of mine, but that's costly. That's about $100. So that's now Dr. Shubhen Bhattacharya has come up with a pupil expander. It is commercially available, no financial interest. It will be available in the Joja stalls. I've used them. They're good. So, you know, the moment you see that wobble in the iris, when you are entering with the probe or when you are doing the rexis, because, you know, the ideal time to put in the pupil expanders are, because, you know, when you have done the rexis and then you are putting the pupil expanders, you have to be careful. You have to inject viscoelastic between the rexis and the iris, not over the iris, because you need that gap. Otherwise, the clips may catch the rexis itself. So, that's the trick about handling floppy iris syndromes. There is no other way. Atropine or stopping tamsuline doesn't help.
Thank you very much.
Good morning, sir. I am Chiranjit from Kolkata. Sir, I have seen many videos demonstrating the pre-chopping technique. It looks very tempting, but I don't know how it helps or whether we should try it or not.
Now, the Akahoshi pre-choppers, Akahoshi again had come to our hospital. He did live surgeries. It's a good technique, but what happens is that those pre-choppers, you know, they get blunt and they are not as effective. And I would not actually recommend pre-chopping with these pre-choppers as for a beginner. I mean, later in some part of your time, if you can, pick it up. And if you really want to do pre-chops or you're fascinated by it, do wet labs, chop them in the goat's eye. If you can regularly do pre-chopping in the goat's eye, you'll do it in the human eye. Then go ahead and do it. Not a problem. But our experience has been that, you know, because the tip becomes a little blunt with the Indian, because the ASICO pre-choppers are awfully expensive. And there are 3 models of it, one for the softer cataracts with the blades, one for the harder cataracts which is sharp, so you need to just go in and put in and then engage, support the nucleus with the other in the equator with a blunt instrument and then impel it and then crack it with the chopper, with that pre-chopper. So that sharpness of that tip of the pre-chopper goes away after some time, and then it doesn't work for grade 3, grade 4. For the softer cataracts, yes, I think we have a pre-chopper, no? Bhaskar?
Yes, we have tried. But
No, we have one pre-chopper, some kind of an instrument
but as you
made,
have
no?
mentioned that the sharpness goes easily.
Yeah, that's what. So
Very difficult
pre-chopping
to
is
master.
something we won't recommend, but if you're fascinated, you can try it in the wet lab and go ahead.
Thank you. Thank you.
We have another 5 minutes. Can any seniors make some comments like the professor made from Jaipur regarding some learning trips? So how many are you all doing FACO? Please. Can we have a raise of hands?
One question.
Yeah. And people who are just doing SiCS thinking to convert. Good. Very good. I mean, I think this course was exactly for you. And of course, you know, in your initial stages, we do have problems. Yes, ma'am. Please come.
Can you hear me, sir?
Yeah,
Okay.
perfectly.
Yes. After doing a perfect FACO, sometimes I find, you know, PCR, I haven't done anything wrong, but that is a setback for me, you know. So how to avoid, like how to make myself, say 99% sure that doesn't happen, even after doing all the techniques correctly, textbook way.
Okay. So PCR, you are getting perhaps more PCR than you usually want. Nobody wants a PCR in the first place. Now, obviously, in the end stage emulsification, if you have PCR, the commonest thing is an empty bag, and if your machine is not very compliant and the parameters are a little high, there can be a surge and you can actually pick up the empty bag, meaning the posterior capsule, and you could have given an energy blown out in that. When exactly do you get the PCRs most often? Is it in halfway through your new emulsifying procedure, in your cortical cleaning, because that is where most of the surgeons get it, or is it at the end stage fragment removal?
So I'm confused when I get it at the end of the surgery when everything has gone perfectly well.
Okay. So, one thing is that it could have happened before and you couldn't identify it because, the identification marks are the chamber suddenly becomes a little deep and the fragments don't move as much it should move, and when you're trying to rotate the new fragments in the bag, they don't rotate because there is vitreous. So these are the pre-symptoms which tell us that PCR has already happened when there are nuclear remnants in the bag. And end stage is the only thing that can happen is the sudden surge or whatever little surge that occurs with machines that takes in the posterior capsule. So in that case, we have to give a lot of viscoelastic to tamponate the posterior segment, posterior capsule in the end stage emulsification. Another thing that commonly sometimes happens is, our probe comes out of the incision a little bit. So in fact, the irrigation comes out, the irrigation ports. So there are no irrigation and there is energy in the last stages. Can happen. Or something very close to the incision if you are emulsifying. Sometimes it happens that the irrigation port are in the tunnel or outside the tunnel. Part of it is outside the tunnel. There is no irrigation and you have used energy. So you need to be careful on these things.
And I think we can record all our surgeries because at that time we are so tense we don't know what we did wrong.
Exactly.
So record all the surgeries and then review them and you'll see what you did wrong.
Absolutely. And let me add another thing. If you have a beam splitter, don't spend unnecessary on fancy cameras. All the good recordings, even my recording is a very new one, so probably those were on security HD cameras costing only 10,000 rupees. Korean security color HD cameras. Go to Alibaba and you can buy them. In case you're having any problems procuring them, write to us, we'll help you in that purchase. Have a recording system as Professor recommended because it helps us evaluating and correcting our learning process. So I think we are done for the course. Thank you very much for supporting us, and we feel so excited about this whole thing. You can go to YouTube and download this course anytime you want. If you want a DVD, there's there on the right hand corner of the gate as you leave. Thank you very much.